Most people think orthopedic surgery is just about fixing a problem, replace a joint, repair the injury, and move on. But the reality is, how we approach these decisions, when to operate, and how to guide recovery can completely change a patient's outcome. And that's what this podcast is all about. Welcome to the Joint Replacement Podcast. I'm Matthew Sloan, orthopedic surgeon and joint replacement specialist. And each week we break down the biggest questions in joint replacement and orthopedic care, what actually matters, what's changing, and what patients need to know to get the best results. Today's episode is a great one. Today's guest is Dr. Siddiqi, an orthopedic surgeon known for delivering high-level, patient-centered care with a focus on modern surgical techniques and outcomes-driven treatment. His practice emphasizes individualized care, advanced surgical solutions, and a commitment to optimizing recovery, not just performing surgery. He has built a reputation for combining technical precision with a strong focus on the patient experience, from initial consultation all the way through recovery. In this episode, we're going to dive into his approach to orthopedic care, how he thinks about surgical decision-making, and what patients should really be looking for when choosing a surgeon. He recently joined Texas Center for Joint Replacement, a legacy practice in North Dallas. Dr. Siddiqi, welcome to the podcast.
Thanks so much for having me. I'm pretty excited about this.
Yeah, absolutely. So I just wanted to start off and have you, in your own words, tell us a little bit about your practice.
Yeah, so I'm about 5.5 years into practice. I finished my additional training and I joined a private practice in New Jersey. I'm actually joining a legacy practice in North Dallas, which I'm super excited about. In private practice, I learned a tremendous amount, got a lot of experience and exposure, but I'm really looking forward to the next chapter of my professional career.
And what made you decide to specialize in hip and knee replacement?
Growing up, my grandmother, my mom's mom, had really bad rheumatoid arthritis, and now this is like several years ago. This is before some of the newer medications really controlled rheumatoid. Was when rheumatoid arthritis was pretty debilitating, and the only way to manage it was just chronic pain medicines or joint replacement. But joint replacement at that time, 25 years ago, was 2 weeks in the hospital, another 3 to 4 weeks at a rehab center, very extensive. And I remember, seeing her go through that. It was life-changing for her. Now it's a foreign concept if we tell somebody that they'll be in the hospital for about 2 to 3 weeks and then go to rehab for another month. But just seeing that recovery, it really stuck with me. And I remember 5-6 years old, just seeing her recover through it. And for someone who couldn't bend their knee or walk with significant pain, it really changed her life. And then she had her other knee done. And then since this was before some of the better plastics out there, she did have a few revisions after that. But regardless of how many surgeries she underwent, it was very life-changing for her. So I knew I wanted to do something that was in that realm, getting patients back to their quality of life and their activities of daily living at a more comfortable level. And I wasn't one of those people that had an ACL injury, and I was very fortunate enough not to have a major injury, fracture, or anything like that inhibited my sports career in high school and college. But seeing my grandmother recover and her experience really resonated with me, and I knew I wanted to do something of that sort. So I went into orthopedics with an open mind, but I knew in the back of my mind that I leaned towards joint replacement. And I really enjoyed the surgeries. I enjoyed the follow-up. I enjoyed the patient interaction. And I was fortunate enough to get the subspecialty training in joint replacement. I think the years that you and I were looking for additional training, it was a curve where everybody was going into joint replacement. So it was very competitive those couple of years, but fortunate enough to having gone to a really great additional training fellowship and went to private practice and basically living the dream.
That's great. And do you want to talk a little bit about your fellowship and what you did there?
Yeah, so my year was 2019, 2020, infamous for COVID. So I had a great half of the fellowship. We did a lot of cases. I was at the Cleveland Clinic in Cleveland. So once COVID hit, we were down for the count for about 6 weeks or so, but then we got back into it relatively pretty quickly. So it didn't really affect the experience that much. It was a great fellowship. It was very hands-on. They basically hired the fellows as staff. So we were able to do our own cases. Any call cases that came in, the residents would seek seek us out to staff it. And so we got treated just like our mentors and attendings. And that was a unique experience that gave us a glimpse into how attending life would be several months beforehand. We had to make clinical decisions without attending support, and it made you really analyze and make decisions a little bit differently. So it was a great year. It was one of the best years of my life, to be completely honest. I do miss it. I keep in touch with all my mentors. It's the perfect, I think fellowship is the perfect time in your training. You're independent enough where you know exactly what you're doing, but you're still under the shade and umbrella of an attending if you need it. And the year passes by super quick. So it was definitely a time that I cherished dearly.
Yeah, absolutely. I know most folks say residency, pay your dues, but that fellowship is usually the best year of training. So it sounds like that was the case for you too.
Absolutely.
What would you say is your philosophy when deciding who should have a joint replacement surgery?
So when I talk to patients, there's a variety of patients. You get different flavors. There's a percentage of patients that come in and say, listen, I've done everything. I need surgery. Let's talk about surgery. And they've already made up their mind. Then there's another percentage of patients that say, I'm here to see you because so-and-so told me to see you, or you got good reviews, or for whatever reason, my knee hurts, my hip hurts. I'm not looking for surgery. I'm looking for ways to avoid it. And in their mind, they made up that no matter how bad their arthritis may be, now is not the time for them. And that's completely okay. This is a purely quality of life procedure, so there's no emergency to this necessarily. Then there's a decent percentage of patients that kind of come to you for guidance. What should I do, doc? Should I have surgery? Should I not have surgery? And those are the patients I spend an extra couple minutes talking about what their expectations are and try to tease out where they are, where their headspace is at. I think if you're ever in a situation where you're trying to convince a patient to have surgery, they're probably not going to have the best outcome because their mind is not into it. I tell patients this is, I give them a few different scenarios, but surgery is 80-20. It's 20% me. I used to say 50-50, and then I quickly realized it's not really 50-50. It's 80-20. It's 20% me and 80% the patient. And I think the more years I get with experience, that percentage that I'm responsible for will continue to shrink, and the patient's responsibility will increase. It's the physical component, and then it's the mental component. Physically, they could be well fit for surgery and they could have a really great physical outcome, but if mentally their headspace is not in it, or if they're not willing to anticipate the pain and the rehab and the swelling or whatever they may experience, then they're going to have a terrible outcome. They're going to regret it. They're going to wish they never did it. Convincing is not in my mindset at all when I'm talking to patients about surgery. I give them their options. I tell them if you're having more bad days than good days, it's something to consider. If you're debilitated, if you can't do the things that you want to do and it's getting in the way and it's upsetting you and you're feeling bummed out, then maybe it's something to consider. If you're able to do what you need to do and you can manage with medications and injections and therapy and icing and bracing, and that's not debilitating to you, it's not disruptive for your life, then you don't have to do anything. And then we talk about their social life and their work status and what they do and what they want to get back to doing. So if I get a sense that they're making excuses in some way to not having it done, then surgery is not for them, and that's completely okay, and I'm very upfront about it. And then patients sometimes say, if you were me, what would you do? And it's a very difficult question to answer. At the end of the day, I don't live with that hip pain. I don't live with that knee pain. I don't know what your threshold is. I know what my threshold is, but I don't know what your threshold is. So it's a very difficult question to answer, so I just try to give them those same situations. And then my best way to end that or steer that conversation is, if you're asking questions, if you're ready for surgery or not ready for surgery, if you should do it, that's the way I'm perceiving it. You're not ready for surgery, because the ones that want surgery say, listen, I've done everything, like I don't care what you say, let's book the surgery. Those are the patients that are mentally ready for surgery. So if you're even having to ask if you should have surgery or not, that means mentally you're not there. So you have to be mentally ready. You have to be all in. It's a long recovery. It's like a training for the marathon. It's final sale. There's no return policy. So, if you don't like it, you can't have your original knee back. So it's one of those decisions you have to make sure you're fully understanding of what you're about to endure.
Yeah, amazing. I have a very similar conversation with my patients, and I think it's similar to what you're saying. The big thing I always tell folks is if you're not sure if you're ready, you're probably not ready yet. And there's no problem coming back in 3 months and checking back in. But it's not, usually when I see people in the office, I end the visit by saying, you don't have to make any decisions today. Just call us when you're ready.
What I also tell patients is as you get busier and you scale, one of the things that patients often say is, it took me several weeks to months to get this appointment visit. If I need something, how do I get in touch with you? I tell patients that the way this, once you see me, once you see my physician assistant, you're in the system, you're part of the family. So it's always easier to get a follow-up than sometimes a new patient slot. And I think patients sometimes feel pressured, like they have to make a decision. But one of the things that from experience I've really made a conscious effort is, listen, if you need to get in, we can get you in. Sometimes with new patients, then those slots and the way the computer systems are designed, it doesn't allow you new patients to squeeze in, but once you're part of the family, always gets preference.
Yeah. And what in your experience from people you've seen in your training and maybe surgeons you've worked with separates a good joint replacement surgeon from a great joint replacement surgeon?
I think the beauty of training is you pick a lot of things that you want to incorporate into practice and what you resonate with, and you incorporate a lot of things that you don't want to incorporate, that you don't want to instill in your practice. I think what resonates to me the most is when you treat patient very much individualized. So you take into account more than just the x-rays, right? So it's easy to tell based on an x-ray or an MRI if they have arthritis or not. I think the difference between a good surgeon and a great surgeon is, number one, figuring out which patient will benefit from surgery, but not just benefit from surgery, will benefit from surgery in that moment in time. Mm-hmm. Is that dysplasia or that AVN? What does that mean to them? Are they having a lot of symptoms just because they have, let's say, stage 4 AVN, or where the ball is dying off and they have a lot of inflammation, but they're not having any symptoms, right? So do you worry about that hip collapsing, or do you wait till it collapses? These are some of the questions that it's the art of knowing if surgery is appropriate at that moment in time. So I think the ones that distinguish is taking everything into account and then having a dialogue with the patient. It's very easy to get in that mindset saying, you have bad arthritis, you need surgery, when do you want to do it? As you get into a routine, because as surgeons, we love to operate, but it's important to really piece the surgery and the patient scenario and their lifestyle and what they're looking to get out of it. It's important to know, to unitize those things. So that's what I learned tremendously by a couple surgeons in residency, and definitely surgeons in fellowship as well, and through experience as well. There are certain patients that I wish they're not having the best outcome in their own mind, even though x-rays look good, everything feels good. I know they're physically better, but mentally they got pressured into doing it from family members or whatever it may be. So it's important to understand where the patient's mental space is at, as well as their physical limitations.
Yeah, absolutely. And when a patient asks you how long is their joint replacement going to last, what do you tell them?
I usually tell them it's about 0.5% failure every year. So instead of saying it's going to last 20 or 30 years, I give them percentages. I tell them, so if it's a 0.5% failure every year, the chances of them having the same hip or knee replacement in 30 years, it's about 80%. And those are really good odds. And most patients that are having surgery on average are anywhere from 50s, high 40s to 80s, 90s. But the average is around 60, 65. So when you tell them those odds, then they're pretty comfortable. You never give them a guarantee. You tell them barring there's no complications or any adverse events, but on average it's about 0.5% failure a year.
And a big thing that makes patients in my practice nervous about the surgery is how painful is the recovery, and how long does the recovery take? What do you tell patients about that?
So I spend a lot of time highlighting or detailing expectations. I think patients get anxious about surgery because they don't know what to expect, and then they don't know where to find the answers when they're in that situation. So there's a couple ways I handle that. Pain is hard to anticipate. Pain is hard to it's hard to objectify, like who's going to have a lot of pain, who's not going to have a lot of pain. So generally speaking, I tell them it's a very painful procedure. I try to not scare them, but I try to err on the side of caution and tell them, listen, you're going to have a lot of pain. This pain, the surgery is not going to make you 0 out of 10 pain. If you're at an 8 out of 10 and it's going to get you to 3 out of 10, that's a home run. So you may still have some residual aches and pains, but it'll be better from where you're starting. I really highlight the multimodal pain that we really approach patients with. I give them a lot of non-narcotics. There's a lot of pills that they have to take, but they all work synergistically. I'm a big believer in nutrition and vitamins and all those things as well, and I do think that has a role and it does help patients as well. So tell them that it's going to be painful, but if you follow the protocol, the chances of you having uncontrollable pain will be minimized. And that kind of gets them into a gear, okay, I gotta follow what doc is saying. In terms of recovery, I break it down based on weeks to months to years. So I tell them 85% of their recovery is roughly in the first 3 months, and then the remaining 15% occurs from 3 months to about 15 months. Patients see a tremendous amount of improvements in the first 12 weeks, and then month 4, month 5, month 6, they get frustrated because they're not improving, as well. And I tell them that plateau or that slow progression happens to everybody, no matter how quickly you recover in the first several weeks. And I tell them it's a 15-month recovery. You may feel great at 6 months, but you might have some limitations, whether it's deep flexion or kneeling or whatever it may be. You got to give it the full 15 months. And the reaction for a lot of patients are like, oh my God, I was hoping to get back 100% in 3 weeks. And it's just maintaining expectations. So I really drill in them the 15-month recovery. And if they recover and they feel 100% before, then that's great. But on average, it's around a 12 to 15-month recovery.
Yeah. And how about work? What do you get into about returning to work with your patients?
I tell them on average it's about 6 to 8 weeks. We can give them up to 12 weeks off in short-term disability, but it's also depends on what kind of work they do. I think my nurse patient, it's around a full 12-week recovery, standing for 10-hour shifts. That's pretty taxing on them. If someone has a desk job, they can probably get back a lot sooner, on average 6 to 8 weeks, but at the end of the day, they can get back to work whenever they feel comfortable. Some people really push to get back to work in 2 weeks, but I tell them, listen, it's a marathon. You got to focus on yourself. There's always going to be work. There's always going to be things to do, but just give yourself 6 to 8 weeks minimum. Again, you can take up to 12 weeks off in short-term disability, and if you get back sooner, you get back sooner. But this is a time in your entire life, the 6 to 8 weeks or up to 12 weeks can determine how you have a longer-term outcome. So there's no reason to push yourself to get back to work really quickly and have a complication. You have a fall, you do something that can compromise your surgery. There's nothing worse than that. So focus on yourself.
Yeah, absolutely. And how about other activities? Like, when can patients return to sports or different types of exercise?
So exercise, I generally tell them about 6 weeks. Just light exercise, upper body exercising is fine almost right away, but stay away from heavy weights. Golf, tennis around 3 months, biking outdoors around 6 to 8 weeks, higher impact activities, snowboarding, skiing about 9 months to a year. Those are generally my guidelines.
Yeah. And what is the biggest mistake you think patients make after surgery?
I think the biggest mistake is, especially after hip surgery, I see this a lot. They feel so good so quickly that they think that they're the exception to the rule. They're not going to have the pain and swelling. I think patients, when they've been in pain for so long, even after knee replacement, they'll have a period within the first 6 weeks where they feel pretty good. And then the next day they feel pretty good. And the day after they feel pretty good. And then they go guns blazing. And they go walk 2 miles, they mow the lawn, they do this, they do that. And then all of a sudden we get the phone calls, unbelievable pain, can't put any weight on it, I think I broke my hip, I think I broke my knee, I'm going to go to the ER. And I think patients just have to realize it's a slow recovery. You have to treat this like a marathon. What I've been really telling patients more often now from the get-go is you got to treat this is like an ankle sprain times 1,000. If you sprain your ankle, you twist your ankle, you go to urgent care, they're not going to tell you to go to PT 3 times a week and do this and do that. They're going to give you crutches, they're going to tell you to ice your ankle and just ice it, elevate it, and wait till the swelling and the inflammation improves. This is no different. What we do in surgery, it causes tremendous inflammation. If you're in a state or period of inflammation and you're really pushing your hip or your knee, your body's reaction is going to be to have more swelling. It's going to get worse. Just take it slow and steady. Even if you're feeling pretty good, it's a long recovery. And if you do have the swelling, if you do have the pain, it's okay. It's part of the course. But I think patients, if you don't highlight some of these expectations, then they get really worried.
Yeah. And what innovations in joint replacement are you most excited about?
There's actually a bunch. I think over the last couple of years when we trained, we saw the evolution of robotics. Even when you and I were in residency, robotics was a thing. There was one or two companies that had it, but over the last 5 years, it's really blown up. And has it blown up because of the industry pushing for it? Is it patient supporting for it? The research goes either way. But I think right now we're in a unique time where we have so much technology available to us that we're in a big data collection mode. So no matter what technology that we use, we're in this era where we're just collecting data. What we do with the data, we don't know just yet. I think it's going to take a few years, maybe another 10 years, until we have millions of data points and then we can identify what to do with it. Ultimately, what I'm the most excited about is in a decade from now, maybe, or maybe sooner, where we can start to phenotype patients. So we can have all these data points. We can predict which patients are going to have a great outcome. We can predict which patients will struggle a little bit. I think if you look at, so the way talking to one of the companies, he really made me look at it a little bit differently. So when EKGs came out, the squiggly lines, how orthopods say it, when EKGs came out, they didn't really know what it meant. So they looked at the trend. So if you had this segment that was elevated, then that means you're having a heart attack. If this segment was elongated, that means you might have a heart block. And that was determined based on seeing hundreds of thousands of pattern. This elevation is associated with this. So we should be able to do the same thing with hip replacements and knee replacements. If patients, the way they're walking, the number of steps or their range of motion or their gait is altered a little bit, maybe it'll help identify a patient that's predisposed to having a stroke or a blood clot or a heart attack, or the holy grail would be to have an infection. So I think when we have all these data points, we're going to be able to look back on it, review it backwards, and be able to identify which patients are at a certain risk. So ultimately, in the next 10 to 15 years, it would be great to be like, okay, Mrs. Smith, you're 68 years old, your BMI is 28, you have diabetes, you have high blood pressure, you have this heart condition, your range of motion for your knee is full, you can make it fully straight and you can bend it a little shy of 90 degrees. You have a 20% chance of having stiffness after surgery. You have a 25% chance of having a blood clot based on all the data points we have. So that changes how you approach that patient. I think it's really going to make every patient super individualized, and the predictability is going to be hopefully very accurate, that we can minimize complications. So I think I'm digressing a little bit, but I think the value of robotics and technology is not necessarily the benefit for right now, but it's going to be the benefit for the future, where we can help identify some of these things and really move the needle.
Yeah. And I think for my practice, we'll talk about this a little bit, but I'm almost exclusively robotic assisted for my primary joint replacements. And I think that patients get the sense that we're at that place you're talking about already, that we just type something into the computer and it spits out the knee replacement. But really, for me, the robot is just an updated tool. And I'm using my own surgeon's intuition and what feels right for me to put the knee replacement in, just with a little bit more precision than I would have with manual instruments. But yeah, I'm really looking forward to the time point where you're talking about we have that extra information to put in exactly what the patient is telling us, look at all the factors that are going to be risks for them, and really dial in the individualized care. So that sounds like what we've all been working towards.
Yep.
And what do you think joint replacement will look like in 10 to 20 years?
I think some sort of utilization of technology, whether that's robotics or AI or augmented reality, I think that's going to be the standard. I think the era of using just conventional, traditional instrumentation and the traditional way of doing things is going to be outdated. And the idea behind that is variance reduction. I think the debate in the orthopedic community, whether robotics, not robotics, my success rate is the same as robotics when I don't use robotics. So all those things I think are a moot point. I think we're looking at it a little bit differently. I think we have to agree on that you have to evolve with the times, and no matter how perfect you think you are as a human, there's an element of human error. And if you can streamline that, and for the benefit of the patient, you can decrease the outliers, that's the value. It's the variance reduction. It's not necessarily improving the mean outcomes. I think that's where the value of technology is, and I think more and more we're going to continue to see that. And I think insurance companies are going to come on board eventually as well. If you look at any high quality, high efficiency industry, aviation industry, automobile industry, it's not necessarily, they don't value the production system, the assembly line system in improving the quality of what they're making. It's all about variance reduction. And that's what the value is. Same thing with insurance companies. You don't get insured based on improving outcomes. You get better rates and everything if you're decreasing your outliers. That's where the cost savings is. So I think the ideological shift is going to certainly happen, and I think it's going to become the standard of care. I think whether you use this robot versus that robot, it's a moot point. I think there's going to come a time where you have to use some sort of technology because it's going to only enhance your surgical ability and your outcomes.
Yeah. So I want to dive into some of the specifics of the technical aspect of your practice. So I'm going to run through some rapid fire questions and just get your take on the topic. Cemented versus cementless total knee replacement.
Cementless. I'm almost 99.9% cementless.
Okay. And what do you think the advantage is?
There's a couple. So I think biological ingrowth, I think there's nothing better than that. The time that the bone cement is the strongest from the time it's put in, when the patient passes essentially, is the time that it's put in. So I think you're on the clock. Once cement goes in and hardens, it only gets weaker with time. Doesn't mean it will loosen or anything like that. It's been the gold standard for years and years. But once bone grows into an implant that can accommodate for that, there's nothing better than biological ingrowth. And the second thing is it's time. It's a little bit quicker. So it's an era of efficiency and volume. If you can save 3 minutes or 4 minutes every case, then you add that up, you can do another case or two.
Yeah, and certainly from a patient standpoint, the less time you need to be under anesthesia, the better.
Absolutely.
Posterior versus anterior hip approach.
So I'm all anterior.
Does that include revision surgeries as well? And if there are certain revisions that you would do posterior, what would those look like?
So if there's anything acute from a posterior column or posterior wall standpoint, that's the only indication for me to go posterior. Otherwise, I do all my revisions anteriorly. And honestly, I've been leaning more and more towards doing some of those isolated posterior column issues anteriorly as well. You can certainly get a good exposure with that. It's a little bit more challenging, but to me, in my hands, everything's easier to go anterior.
Yeah, and even if you know that you're going to have to remove a femoral stem, you would do that from the front as well?
I do, yeah.
Yeah. And are you on table, using a hand table or something similar, or off table?
So I do both. My bread and butter and my workhorse is doing with the table. There were certain facilities that didn't have a second table if I'm bouncing rooms, so I certainly can do it off table. My preference is to do it on table, but some complicated revisions, believe it or not, it's a little bit easier to do it off table. I can go either way, it depends on the facility, if there's another surgeon that needs a table, so I can do it both ways, but I definitely prefer the table. It's a lot more controlled, it's a little bit easier.
Yeah. And how about partial versus total knee replacement? Do you lean more towards partial for people who are candidates, or do you push the envelope on the partial knee replacement, or do you lean more towards a total knee if there's any question about multiple compartments?
So I definitely am a big believer of partial knees. I definitely push the envelope a little bit. I think anybody above 70 years old that has isolated medial or lateral compartment arthritis, I don't look at the patella at all. And even if they have a little bit contralateral compartment arthritis, but they're not having pain, I'll still push the envelope, especially some of these older patients. I think they recover so much better. There's honestly nothing better than a happy partial knee patients, and there's a lot more happier partial knee patients out there than there are full knee replacement patients out there. So I'm definitely pushing the envelope.
And what sort of conversation do you have with your partial knee patients?
I tell them this is a definitive procedure. This is not a bridging procedure, because that's what everyone has the concern. I don't want to have a full knee replacement a couple years down the line. I tell them, listen, if there's any concern that you have arthritis in any on the other part of the compartment, then we'll do a full knee replacement. I'm a little bit more particular on younger patients. If I see some arthritis in a 45, 50-year-old, then I'm probably doing a full knee replacement. But like I said, 70, 75-year-old, I think by the time they have any issues, I think they'll be old enough where it's not going to even be an issue, to be completely honest.
And how about, you mentioned medial and lateral. Are you doing many patellofemoral unicompartmental?
Just a handful. I honestly don't see a lot of those patients. If there's a really young patient, I think I've done them in a 30-year-old and a 25-year-old where they had a Fulkerson osteotomy, patellofemoral issues, and then they just had patellofemoral arthritis. I prefer to do a partial in that situation because at that age they're going to have some sort of revision down the line, so it's a little bit easier to revise those. But I just don't see a lot of those, and the data's pretty clear on that. They don't do as well as a medial or lateral unicompartmental.
Yeah. And for your lateral partial knee replacements, are you doing a lateral parapatellar approach?
I am, yeah. I'll do a lateral mini mid vastus essentially. Lateral unis are definitely a little bit more challenging. But those patients do very well.
Yep. Absolutely. And have you had to come back? And if you have come back on a lateral or revise someone else's lateral, do you go through the lateral approach again to convert to a total knee replacement?
It depends how long after it is. I think if it's been several years, then I'll do my traditional medial incision and make sure there's enough skin to bridge. But if it's relatively recent, within a year or two, then I'm definitely going along the same incision.
Tell me about your general total knee approach. Are you doing a minimally invasive approach or standard medial parapatellar?
I'm doing subvastus on everybody, and I do that medial oblique incision. It's worked out tremendously. Patients do see a lot more bruising with that approach, and I warn them ahead of time. It's not painful, but they definitely see bruising. It's been great, honestly. The subvastus has been a workhorse for mine for revisions as well. It's hard to say if I'm seeing a tremendous difference. I think patellofemoral articulation is just not an issue. I think that the patella tracks perfectly when you go subvastus. Do they have a little bit better range of motion? Yeah, they probably have a little bit better range of motion. You're not getting into any of the muscles, or the quads don't shut down or anything like that necessarily. But I think I would take it with a grain of salt. Everybody that says it's a tremendous improvement, I think it's a little bit better, but excuse me. But I don't think it's one of those things this is the reason why patients are doing that much better. I think you see some gains here and there in the short term.
Right. And we touched on this a little bit, but robotic assisted or manual for knee replacements or hip replacements?
So just like you, I'm robotic for everybody. I'm robotic hips and I'm robotic knees, and it's entirely because I want to decrease my outliers when we're doing an increased number of cases, ergonomically for myself, my posture, the way I'm standing, the stresses and everything. I want to have a long career. It just makes me stand a little bit upright, stand a little bit better. I can look straight. I'm not looking down all the time, so I can hopefully save my neck a little bit. And it's the reproducibility, whether you're doing 6 cases or 10 cases or 12 cases, the precision and accuracy from your 6 a.m. or 7 a.m. case to 3 p.m., 4 p.m., or however late it might be, it's the same. There's really no element of fatigue that sets in when you're using technology. And I want to contribute to the data collection part of it as well, so we can have better decision making for the future. So it's all those things. I think variance reduction is a tremendous value for patients. If it was me that was having it done, I would leave it up to whatever the surgeon felt the most comfortable with, but I would probably seek out a robotic surgeon because it's very clear they decrease outliers, and that's the value.
Yeah. And how about operating at a surgery center versus at a hospital setting versus doing outpatient surgery at a hospital setting?
So, big believer in surgery center. I think the experience is more like a country club, concierge. It's really nice. You have 3 nurses looking after 1 patient as opposed to 1 nurse looking after 8 patients. Pretty much same day. Even if I am at the hospital for whatever reason, I just gear patients to go home the same day, including bilaterals, revisions. Everyone's geared to go home the same day. I think patients just do better mentally when they're in the comfort of their own home. And this whole concept of, oh my God, if something happens overnight, I feel comfortable to be at the hospital. But if you look at the data, anything that's going to be catastrophic will most likely happen 72 hours to 96 hours after surgery. So even if you spend the night in the hospital, you're missing the window of something, God forbid, bad really happening. So for those reasons, it's just better to go home.
Yep, absolutely. I have the same conversation. Do you know roughly about what percentage you do outpatient versus overnight?
It's probably 99% outpatient.
Okay.
Yeah. And a lot of that is identifying, is just setting expectations. I'm not the to create this. It took a lot of like work, because the moment a physical therapist or a substitute case manager or a per diem nurse says, "Oh, you're gonna spend the night," everything derails. So
Right.
everyone, every step of the way, from before surgery, months leading up to surgery, to the day of surgery, has to be, you're going home in a couple of hours. You're going home in a couple of hours. And that's what becomes the expectation. And the moment someone says, "Hey, you're going to be able to spend the night," it becomes a problem. So there's a lot of time spent to creating that culture. And that's very important. I think pre-op education, the most important thing, to set expectations. And that's the mental side of it as well, because if I geared every patient to say, "Hey, listen, you're going to be in a ton of pain medicines are not going to help, you're going to be in the hospital for 2 weeks," and that same patient, if you tell them after surgery, "Hey, everything went great, you can go home," they're going to say, "Absolutely not, I'm not, there's no way." But that same patient, if you gear them the opposite way, "Hey, you're going to be okay, you're going to have pain and discomfort, but you're going to take medicines ahead of time, and it's going to be okay, and we're easily accessible, and you can call us anytime, we'll get in touch with you, and you're going to be able to go home in 2 hours," and make sure your home is set up ahead of time. You have enough people. You have the social side of it set up where someone's going to be able to come help you. And if sometimes you gear them so much and you tell them, "Listen, like, if you want to spend the night, you can spend the night." There's a lot of patients that say, "No, you told me I'm going home. I'm ready to go home." So it's
Yeah.
about creating that expectation. And that's not a once or twice thing. It's hours and hours spent from myself and my staff that set that up for patients.
That sounds like you guys have really worked out the kinks. So, do you prescribe prehab to your patients, or do you have a structured home exercise plan that patients can work on before surgery?
So they do have a home exercise program. I use a lot of a digital care platform that basically it starts 30 days before surgery and continues 90 days after surgery. So it's a pretty structured program where they have exercises. They're pretty simple for the young active patients. They always tell me this is super easy, but it's a touch point. If you want to do more, you can do more, but it gives you something to do. It's a checklist, and the data is pretty clear on that. I tell patients, whether you go to outpatient physical therapy before or after surgery, there's better evidencing that home exercise is probably a little bit better, compliance is a little bit higher, and only you know how you're doing. And once you put the onus on them, tell them that 80% of their recovery is on them, then a lot of them are motivated. And there are some patients that are really fixed on going to outpatient therapy before and after surgery, and if you try to, again, convince them not to go, then those are the ones that are going to regret not going, or they're going to have an issue, and it's going to be a blame session essentially. So if someone is leaning one way or to outpatient therapy pretty heavily, I'll let them go. But I just warned them. I was like, "Listen, you got to do it at your own pace, and you have to be motivated enough." There's no concept of someone's motivating you. The therapists are essentially cheerleaders. They're just cheering you on. If you want a cheerleader, call me and my nurse and my PA will cheer you on. So you have to really enable them. And I think once you do that, most patients are receptive, and they do really well.
Yeah. And switching gears a little bit, what do you use for your closure for hips and knees? Patients ask me a lot, am I going to use glue or staples or stitches? What's your preferred approach for closure?
So I do a particular running Stratafix closure, so it's almost like a plastic surgery closer. And then what actually goes on the incision itself, I used to use zip line a lot. They're basically zip ties that go on the incision, but I've transferred over to a silk-based, it's called silk-based product, where it basically just kind of adheres to the incision. I just have patients leave it alone. They leave it alone for a couple weeks, and then when they see us in the office, we peel it off. But there's no staples, there's no stitches that have to come out. For revisions, I'll use stitches that stay in for several weeks, and they're aware of that, but revisions don't really care much about the cosmetic as the primary. That's what I do.
Yeah, absolutely. And do you use the silk dressing for hips and knees?
I do, yes.
And how about DVT prophylaxis or blood clot prevention?
So I'm pretty much on baby aspirin once or twice a day, depending on their risk profile. If I'm doing bilaterals and they're older than 75 years old, then I'll use a stronger blood thinner. But for the overwhelming majority, I'm using baby aspirin.
What's your take on bilateral surgery? I do it intermittently, but my feeling is that the recovery from doing one side at a time is a little bit easier on the patients, but I certainly have patients who want to consolidate that total recovery timeline.
So my conversation is a little bit different when it comes to hip versus knees. When it comes to knees, I try to discourage them as much as possible. I've never had a bilateral knee patient that was super pumped about it, even though they're gung-ho about it ahead of time, how they're going to crush it, this and that. But they're always miserable, and they're like, I wish I just did one at a time. But there's a lot of social factors, work factors, insurance issues where they have to get both done at the same time, so I take that into account. And I tell them, even that I reference some of our papers that we've published about how even the healthiest of patients, they have 9 times increased risk of something bad happening. We do whatever we can to try to minimize some of those risks. For certain patients, we put them on, again, like I said, higher blood thinners, extended antibiotics if they're a little bit higher risk, things like that. But the rehab is very difficult for knees. Hips, I am a lot more open to doing a lot more hips. I think it's a little bit more difficult when you have bad hips on both sides to rehab one. That interim period is very challenging for a lot of patients, especially how quickly they bounce back. I do, actually, believe it or not, I do a lot of bilateral hips. Patients do awesome, like do really well.
And you talked a little bit about antibiotics for patients. What is your protocol for postoperative antibiotics? Who do you use them for?
So everybody gets 24-hour coverage because everyone's going home 2 hours, 3 hours after surgery. I'll give them a couple of tablets to cover them for a day after surgery. For higher risk patients, elevated BMI, kidney disease, diabetics, patients that stopped smoking recently, allegedly, cancer patients, a remote history of them, or active cancer patients, I'll do a week worth of oral antibiotics. I know some of that is a little bit controversial, but there's some data coming out saying that it is beneficial. So that's just how I approach it.
Yeah. And what is the conversation that you have with your patients about narcotic pain medication? And what have you found to be the best non-narcotic adjunct medication?
It's more as a combination of everything. I'm a big believer of oral steroids, so I'll put patients on 10 to 14 days of oral steroids after surgery, and that's been a tremendous difference maker. I also have been doing extended oral tranexamic acid. The only downside of that is that the pills are really big, and some of these older patients have a tough time swallowing the pills. Even if they break it up, it's pretty large. That's been a tremendous difference. The new medicine, Jernavix, has been a game changer as well. Now it's going to be, because it's covered under the No Pain Act, I think it's going to be a little bit easier to prescribe that and for patients to get it. That's a lot newer. I use a nerve medicine. I use pregabalin, and I think that's been beneficial as well. So the combination, and obviously I use a strong anti-inflammatory. So between all those, patients are relatively comfortable, and I hit them pretty hard on a scheduled basis. These are not medications they can take if they're having pain. These are scheduled around the clock along with Tylenol, and as long as they're taking it scheduled, then they're staying ahead of it. They're not allowing pain to creep in. And obviously we give them some narcotics too, so as breakthrough pain. We try to limit that. We keep a close eye on who's asking for refill and who's not. There's a huge push towards limiting narcotics. I'm not there yet fully, but I think that's the goal, is ultimately to be able to do this 10 pills or less.
Yeah. Yeah, I mean, I think there's a lot of patients who can get there, especially with the hip replacements. Very frequently we have our no narcotic hip replacements, or I took it the day after surgery because the nurse told me I should get ahead of it. The knee replacements, I get a little skeptical when when surgeons really advocate hard for no narcotics for knee replacement patients, and they say that none of their patients need it. There certainly are plenty of patients who can get by without it, but sometimes I feel like the surgeon's philosophy is dictating how much pain their patient's going to be in. So I don't want my patients to be suffering the first couple weeks.
Yeah.
Do you have any hard cutoffs for no surgery, BMI cutoffs or smoking, or what are the red flags for you where you say you just can't have surgery right now?
Obviously, I use the national benchmark of A1C of 8, but I also get a fructosamine level. So if their A1C is an 8, but their fructosamine is like 250, I'm completely okay with that. And I highlight all that to patients as well, as long as it's downtrending. BMI smoking is a dead stop for me. We test everybody 3 to 4 weeks before surgery, and if it's positive, then they're just canceled. There's just no way around that. I've seen too many complications happen with smokers that get referred to me, and it's one of those risk factors that you can't control if you have diabetes or not necessarily. You have to manage it, optimize it, but no matter how hard it is, you can control. You have to control if you're smoking or not. So that's on you. If the pain is bad enough, you'll figure out a way how to stop smoking. In terms of BMI, I don't have a hard and fast BMI cutoff. I just look at the body habitus. There's a lot of BMI 45s, as you as I know, that are pretty bulky up top, but their legs are pretty skinny. And it's the opposite. There's some BMI 28s that have really big legs. And the concern for wound healing is a real problem on the hip side as well as the knee side. So it goes more based on the body habitus and the pannus and things like that, as opposed to a true BMI number.
Yeah. And
Having said that, the surgery center is pretty hard and fast about a BMI 40, 42, so you
yeah,
have to play by their rules.
yeah, exactly. And what advice would you give a patient who is nervous about surgery?
I think what I found is most anxiety and nervousness comes what happens after surgery. Like they know all these expectations, work expectations, driving, when they get back to activities, things like that. But what they want to know is, what if something happens? How easily accessible is my surgeon? Is what I'm doing? Am I along the right course? Is this what I'm supposed to be feeling? If you address some of those things before surgery, but you continuously maintain some of those expectations, I think they feel a lot more comfortable. I think the unknown is what they feel comfortable. I think a lot of patients have this in mind. My care team is with me every step of the way, and then after surgery, they're focused on somebody else. And what I see is, what if something happens? Like, what then? And I think that's why a lot of patients go to the ER. So we as a profession have to do a better job comforting our patients and making them feel, showing that when they touch base with us, that we will address their concerns. So I put a lot of emphasis on my staff. If there's any issues, if I need to call somebody back, tell me right away and I'll do it. Because I don't want a single patient to feel like that they're unheard, or we're not there for them, because they entrusted us for an elective procedure, so we have to be with them every step of the way. This is an elective procedure. This is not a heart attack. This is not an emergency procedure. This is something that they want to get back to playing better golf or tennis or hiking or walking, or whatever it may be. So if they're entrusting us with that, then we have to honor that. We have to maintain that high level of standard to being there for patients. That's what I think that's what makes patients feel a lot more comfortable. Even the day of surgery, I tell them, listen, like, you have any issues? Some patients, I give my personal cell phone, depending on if they're super nervous. I give them direct access to us using the apps that I was telling you about before, and I'm responsive on there. They just want to know that if they have an issue, that there's a method or there's a way in place where they're not waiting days at a time to hear it back. And I think once you do that, they feel way more comfortable.
Yeah, oh, that's great. And along the same line, you have a family member or friend who needs a joint replacement. What advice do you give them on how to pick a surgeon, or how to pick the right surgeon?
So my answer has evolved over the past couple of years. Before, I used to say, just it's whoever you feel the most comfortable with, and that's absolutely true. It's whoever you feel the most comfortable with, but you have to ask questions to tease out the mentality of the surgeon. And I think the more you talk to different doctors, the more you get the flavor of their personalities, or what their ideology is, basically. So I think choosing a surgeon is not necessarily about finding the most famous name or the most well-known name, even though I'm not saying that can't be it, but you have to look a little bit beyond that, because this is, again, your quality of life that you're entrusting somebody that you don't really know at all. And word of mouth reference is great, but you have to keep in mind everybody's different. Just because so-and-so had a really good experience and a really good outcome doesn't mean that you will have the same thing, right? So your hip might be a little bit different, your knee might be a little bit different. You have to get that comfort and rapport with the surgeon. So I think finding the right surgeon is somebody that has a repeatable system, a clear philosophy, and accountability for outcomes. It's not just the operation, but it's everything that happens before it and after it. The surgery itself is like 30, 40, 50 minutes part of your continuum of care entirely, and your life, basically. So you need somebody that you can vibe with, and someone that can understand you before and after surgery. And I think it's also important that patients understand that complications are going to happen. Every surgeon has complications, but the real differentiator is how early the surgeon recognizes the problems and how they manage it. And patients almost never ask this, whether it's out of fear or not thinking about it. I think they really should. They should go something, if something doesn't go perfectly, what is your process of managing it? And a few patients asked me that, and it caught me off guard. But those are the patients that are the most well informed.
Yeah.
And I think patients have to ask those questions, because 90% of the time or 95% of the time, nothing bad will happen. But this is your life. So you want to focus on the 5% if it happens, God forbid, and you're that small percentage. Well, what is my surgeon going to do? And what have they done? What's their philosophy? Same thing with the robotics. Is it just a philosophy that they had because that's what they were trained on? Or is it beyond just my preference? So do they have a good answer to it? So you want to try to understand the mentality and the perspective of the surgeon. If that's something that resonates with you for the most part, then that's your surgeon.
Yeah, that's great. I really appreciate you joining us today. Any other thoughts in closing that you wanted to talk about?
No, this was great. I hope it's beneficial for patients. I think more than the surgery side of things, which is super near and dear, but the reason why we do it is for the patients. And ultimately, it's for not just the patients, but it's for their experience. It's their experience, it's the family experience, and that's what they're going to remember. I think, and this is for all the young surgeons out there that are still in training that are thinking about this, you want to connect with your patients. This is, what you want to connect with your patients. You want to make them feel like that they're the only ones that matter. So the art of what we do is, in this era where we're doing high volume surgery, you want things to function like an assembly line, right? You want everyone to know where their role is, so nothing gets missed. But you don't want a single patient to feel like it's an assembly line. That's the art of it. And I tell my staff that, I tell everybody that I work with, assembly line is not a bad thing. That's how things get automated and streamlined. That's when mistakes don't happen. But patients can't feel that. It has to be individualized. It has to be personable. Patients need to get everyone's time. And that's what we do. We can have a suboptimal outcome, but if they had a great experience, then that's what we do. We're humans. We're not perfect. Mistakes will happen. No matter if we do something perfectly, someone might fall, open up their wound, someone might get a blood clot, but it's what we do about it. We don't put our head in the sand and kind of hide away from it and just chase after the easy cases. We own it. We get patients through it, and we just optimize their experience. Their experience is why we do what we do.
Yeah. It's been great talking with you, Ahmed. Thank you so much. I think this is going to be really helpful for all the patients out there who are thinking about joint replacement. All right, keep doing what
Thanks
you're doing.
so much, Matt.
Yeah, no
Appreciate
problem.
it.
Thank you.